Friends, in this video of ECG basic, today I will talk about left anterior fascicular block. First is a disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or company. The ECG criteria for left anterior fascicular block is left axis deviation, usually minus 45 to minus 90 degree, QR complexes in lead 1 and AVL, RS complexes in lead 2, 3 AVF, prolonged R wave peak time in AVL more than 45 milliseconds. This is a typical ECG of left anterior fascicular block demonstrating RS complex, that is small r, and big S complexes in lead 2, 3 and AVF, and QR complex in lead 1 AVL. We can see a small Q wave and tall R wave in lead 1 and AVL. The left axis deviation lead 2, 3 AVF are negative and lead 1 and AVL are positive. The left anterior fascicular block may have associated features like QRS duration. It may be normal or slightly prolonged, and we can see increased QRS voltage in limb leads. Coming to electrophysiology of left anterior fascicular block, here the impulses are conducted to the left ventricle by posterior fascicle, which inserts into the inferoseptal wall of left ventricle along its endocardial surface. Depolarisation spreads from endocardium to epicardium, and thus the initial vector is directed downward and rightward towards the inferior leads. This produces a small R wave in lead 2, 3 and AVF, and small Q wave in lead 1 and AVL. The major wave of depolarization is slightly delayed and it spreads upward and leftward, so it produces a tall R wave in left-sided leads and deep S wave in the inferior leads. This overall delay of approximately 20 milliseconds as compared with the normal simultaneous conduction by the both fascicle results in slight widening of the QRS complexes. As the impulses reaches the left side leads later than the normal, there is an increased R wave peak time in AVL, that is time from the onset of QRS to peak of R wave. The sequence of conduction in left anterior fascicular block, here we can see in the yellow line, it shows the impulses are conducted to the left ventricle by the posterior fascicle. The red line or the red arrow shows initial depolarization vector is directed towards the inferior lead, and blue arrow, it shows major depolarization vector which is slightly delayed and is directed towards the left-sided leads. In this ECG, we can see QR complexes, that is small q, and tall R complexes in lateral limb leads, and small r and big S complexes in the inferior leads. In this ECG, we can see left axis deviation, lead 1 and AVL are positive, lead 2, 3 and AVF are negative. Here we can see prolonged R wave peak time. Prolonged R wave peak time, that is the time from the onset of QRS to the peak of R wave. In AVL, it is more than 45 milliseconds. In this ECG, we can see left axis deviation, QR complex in lead 1 AVL, RS complex in lead 2, 3 AVF, prolonged R wave peak time in AVL, and increased QRS voltage in limb leads. Here, similar, we can see left axis deviation, QR complexes in lead 1 AVL, RS complex in inferior leads, prolonged R wave peak time in AVL, and slightly prolonged QRS duration. So just remember, in left anterior fascicular block, the QRS voltage in lead AVL may meet the voltage criteria of LVH, that is R wave height more than 11 mm, but there will be no LV strain pattern as seen in left ventricular hypertrophy. Dr. Viktor E. Frankl has said, when we are no longer able to change a situation, we are challenged to change ourselves. With this, I conclude my today's topic on ECG basics. Thank you. Keep learning.